So a lot of patients think that when we do a total knee replacement, we cut the shin bone and we cut the thigh bone and we pull something off of the shelf and we plug it in. And while in really complex situations, tumors or failed joint replacements, that is something that we kind of do. A first time or a primary knee replacement is more of a resurfacing of the knee. There are a couple of things that I do in doing a first-time knee replacement surgery that's a little bit different than other people. I still make an incision over the front of the knee, but instead of cutting the tendon that attaches to the kneecap or the quadriceps tendon, I actually come underneath the muscle and I slide that muscle over the top to get into the knee. What I then do is I use a computer to help me align the cutting guides, and I shave off the very end of the thigh bone, and then I shave off the very top of the shin bone, and I replace those with metal caps. Now, in select patients who have good bone, I do something different here. I use what's called uncemented implants. Traditionally, knee replacement surgery requires that we cement the metal to the bone. The good thing about that is that the metal is bonded to the bone as strong as it ever will be at the time of surgery. The downside to that is that the metal is as strong as it ever will be bonded at the time of surgery and will only get weaker with time. The other issue is that metal introduces grit or sandpaper into the knee that can wear the plastic. So in select patients, in appropriate patients, I use what's called uncemented implants, where there's a special roughened surface on the back of the implants that the bone actually grows into. Now, while this isn't something that grows into immediately, it does take time for the bone to grow into the implants. It's what we call biologic fixation or living fixation, where the bone is constantly being laid down into the channels in the back of the implant and is living with the patient. The benefit of that is that once it has grown, it's a very durable fixation, and we avoid the grit that the cement can introduce into the knee that may affect wear of the plastic and therefore the longevity or how long that implant will last. You know, the decision to undergo an operation like a total knee or a total hip replacement is a very personal one. Ultimately, you as the patient are the decision maker, but it is something that we arrive at together. There's a lot of conservative treatment options when it comes to hip or knee arthritis or hip or knee problems, and I think of those as being a progression. The idea being that you don't assume any more risk than is justifiable. Obviously, surgery carries quite a bit of risk with it, which is why we wait until we've done everything short of an operation. Early on, those treatments may be activity modifications. If it hurts when you jog more than 5 miles, you don't jog 5 miles. You change the way that you're doing things so that you can continue to do what you want to do, but you do it in such a manner or such a way that you're not as limited or in as much discomfort or pain from your arthritis. Other things that we talk about would be over-the-counter medications. These would be anti-inflammatories, acetaminophen. Sometimes we talk about braces, sometimes we do injections. There are 3 different flavors of injections that we have now. The most tried and true, the thing that we've been doing for decades now, is steroid injection. Is actually called Compound F when they were first doing those injections at the Mayo Clinic where I trained. The next injections are the viscosupplementation injections. Some people think of them as joint lube or the rooster comb injections. The third type of injections are the newest in terms of what's been developed, and those are the biologic injections. Those are the platelet-rich plasma injections, the amniotic injections, a procedure we also do called lipogems here. When all of those things have failed, we're also incorporating strengthening exercises, home programs, physical therapy. But when you get to a point where you've done all of those things and your quality of life is suffering, that's when we have a really serious discussion about joint replacement surgery. And that is when it makes the most sense, when you've done all of those safer, simpler treatments, but your quality of life is still being negatively impacted by your joint, that we then move on towards knee or hip replacement surgery. In terms of risk for knee replacement surgery, there's risk anytime you have an operation. Those risks are small, less than 1%, but not zero. There's always potential for damage to nerves, blood vessels, muscles, ligaments, tendons, bone, infection, blood clot. Over time, parts can wear out, parts can become loose. Those risks are rare, but again, not zero. There's also in knee replacement surgery what I call the dirty little secret of knee replacement. And that's something that every surgeon knows, but very few talk about. Over the years, it's been pretty consistent that 80 to 85% of patients are ecstatic with the results of their knee replacement. And that sounds wonderful until you consider that means that leaves 15 to 20% of patients who are better but not perfect. Quite honestly, we don't know why those patients aren't absolutely satisfied or pleased with their result. But I suspect that it has to do with the fact that a knee replacement is not a restoration of what you were born with that God gave you. It is a reconstruction with metal and plastic. And because of that, it doesn't act the same, it doesn't feel the same, and it doesn't even sound the same. And I think people tolerate that. Anymore, knee replacement surgery is really advanced beyond what it was. It wasn't that long ago that people would spend weeks in the hospital after a knee replacement surgery. And in my training, it was the expectation that every patient would stay 3 to 5 days after surgery. And then within the last couple of years of my practice, I've seen that upwards of 85% of my patients will go home the same day. Now, obviously, we have to be safe when we do that. So patients have to be able to get out of bed, get to the bathroom, have their pain controlled, get around safely in terms of pain management, and also be able to eat and drink and void in order to go home safely. And that criteria has to be met whether you're leaving the same day of surgery or the day after. But it really is that rapid progression of mobilization that I've seen that I think makes us much better knee replacement surgeons and makes patients much happier now. When you're up and you're moving, you feel more normal, you feel more human, you don't have as much concern or limitations, and because of that, your pain is improved. And then because your pain's better, you don't have to take as much pain medicine. And that's another thing we do better now, is we don't have to give people a bunch of narcotics anymore because we come at pain from a bunch of different directions. And so we avoid those complications of feeling goofy, not feeling like yourself, upset to your stomach or constipated that we used to see years ago. The other thing is that because we've gotten people up moving faster, you're not losing that strength and that endurance and that stamina that we used to see when people were laid up for weeks at a time. And as a result now, people are back to life much faster. People are back to general activities and doing what they want to be doing within a month to 6 weeks routinely anymore.